Eaton. I'm a nurse practitioner working in Kansas City, Missouri. I work on an inpatient psychiatric unit, so I'm a psychiatric mental health nurse practitioner. I've been doing this job for almost 4 years now, actually 4 years this month, and I was asked to record a short PowerPoint or a short video to accompany the PowerPoint presentation on the psychosocial chapters that you have. So my background is in emergency nursing. Actually, I was an emergency nurse for 8 years. About 2 years of that, I was working in an adult emergency room, and then kind of overlapped 1 year, and then 5 years, 6 years, something like that, working in a pediatric nurse practitioner or pediatric emergency room. We saw every kind of wide variety of presentations in the emergency room, and that's when I first kind of got the knack or the itch to start working with people with psychiatric illness. It's one of those things where when I was working in the adult emergency room, no one wanted to work with the kids, so I kind of got interested in kids, and I went and worked in a kids ER. And then in the kids ER, nobody wanted to work with the kids with behavior issues or psychiatric illness, so I got interested in that and kind of went down that road. So what I want to talk with you about kind of quickly, understanding that most of you, from my understanding, will be working in family practice or at least general practice kind of all across the medical field, is some of the things that you can look out for when you're working in that areas. Some of the things I want to talk about are substance use issues. I want to talk about gathering an accurate and very thorough history, and that's both their psychosocial history, their symptom history, as well as their substance use history. I want to talk about making sure that you're identifying a symptom set and not just trying to diagnose based off what you think it might be, but identifying the primary or the prominent symptom and then going from there. And then the last thing that I'll talk briefly about is suicide and suicide risk, that sort of thing, when to consult, when to refer. So the first thing that I was mentioning a moment ago is substance use. Again, this might go without saying, or it seems obvious and it goes without saying, but making sure that you're gathering an entirely accurate and thorough, extensive substance use history is very important. I found that the first time that I ask, people often lie, or maybe they don't lie, but they forget, or they don't mention the fact that they've been using heroin for 15 years. So I'll ask a couple times. The first time is usually no, I don't use anything, I don't do drugs. And then I say, ever? And then they say, oh, well, drugs. Yeah, I used to do drugs. And then it turns out that used to do drugs means that they did it last week, or they did it yesterday, or something like that. So making sure that you ask the question, and sometimes you have to ask it a couple times. You've got to understand the numbers are a lot of people in the country do use illicit drugs. That's just the fact. So when they say that, their first answer is that they don't use drugs, that might not be accurate. So they use methamphetamine, let's say, and then I'll ask how they were when they first started using, because there's a big difference in the damage that's done to your brain, in the psychosocial lifestyle of someone who uses methamphetamine once ever, or someone who's a daily methamphetamine user for the past 15 years. One of those people might have a better grasp on holding down a job, keeping their daily functions up to date, not impacting their spheres of like academia or occupational spheres or social spheres, and keeping all those intact. And the other one might, have lost a lot of those things due to rampant substance abuse. So, understanding that and understanding the physical things that can be done to your brain, especially with something like methamphetamine or PCP or cocaine, you'll get real actual physical structural brain changes from those, and that's similar to a psychotic illness. So schizophrenia is an inflammatory disease, and each time you have a psychotic break, you lose a little bit more brain. And the classic commercial from the 80s where this is your brain on drugs and it's the egg in the frying pan, it's something that's really accurate. So understanding the substance use issue and how rampant it is very important, and that's why a big part of is this a psychotic illness, or is this something that's caused by substance abuse? That's there. The other big thing is, another obvious thing seems like depression and alcoholism go hand in hand. The three big things that alcohol use is going to affect is your mood, anxiety, and your sleep. So alcohol impacts GABA in your brain, and GABA is the kind of when GABA's turned on, it induces anxiety. It's an anxiolytic property when GABA is activated. So you activate GABA, you get calm, and that's how benzodiazepines work. That's how alcohol works. But when you take that alcohol away, or you take the benzodiazepine away, you'll have rebound anxiety. It's the same with Xanax or something. You take Xanax regularly, you take that away, you have rebound anxiety. So alcohol is a strong tie to depression and anxiety as well as sleep, but chronic alcohol use is a CNS depressant. We all know that. And not a lot of people who drink alcohol daily know that. And not a lot of people who drink alcohol daily are ready to accept that. So making sure you, again, get an accurate alcohol use history. And for me, that entails not only how old were you when you first started drinking, and how often do you drink, all the CAGE assessment questionnaires, all those things, but also your longest period of sobriety. Because someone who has 14 years sober and just started drinking again, that's a different person than someone who's never had any sobriety. So again, these things are pretty important. So that's the substance abuse issue. I mean, that's covering those bases is very important, and covering those just to make sure that you're getting a thorough history, but also, like, could these symptoms be caused by substance abuse? The next thing that I think is very important is gathering an accurate history. And this, again, seems super obvious. Of course, you're going to gather an accurate history. But the problem with, let's say, cardiology is, if I come in and I'm a cardiology patient, the person who's best able to tell you about my cardiology symptoms or my heart symptoms, it's me. I'm the only one who knows that, because I'm the only one who lives with my heart every day. But a lot of times people with psychiatric illness are unable to identify their own symptoms. That's called anagnosia. So when you don't know that you have psychiatric symptoms, or it could be that, they think their anger outbursts are perfectly justified, or they think that, their mania, as Kanye said on his newest album. I think the cover was called, had a saying on it that said something like, I love being bipolar, or I hate being bipolar, or it's great, but it's all about, like, how it's kind of a duality of those things. It gives you, if some people will say, it feels like a superpower, or that sort of thing. So they don't see it as an illness. They don't see it as something that's impacting their ability to function in life. They see it as a superpower. They see it as being able to stay up all day for 7 days in a row and create all sorts of wonderful things. So it's getting an accurate picture. You're not always going to get that accurate picture from the patient. So you want to try to talk to as many sources of information as you can. Sometimes that's the parent. Sometimes it's the wife or loved one or husband or whoever they live with. Sometimes it's multiple people. A lot of times when we have people on the inpatient unit who are there for 96-hour holds, we try to call 2 or 3 people, and getting as many people as you can, as who can speak to all different aspects of their history is obviously hugely important. And it's the same idea as that you would get from, like, requesting past medical records, which we also do, because those are also important. How they looked during previous clinic visits, as far as those psychiatric visits, that's also very important. So making sure that you're gathering an accurate history that's not just accurate for today, but also kind of covers everything that people might have seen over the course of however many years. And this is especially important when it comes to something that's happening now, as far as this person needs to be admitted to the hospital because they're dangerous right now. Well, figuring out if they're dangerous right now, and that's different than how they've been the rest of their life, is pretty important, versus are they dangerous all day, every day? And that's going to be, that's going to be a huge impact on the difference between their treatment. So you need to get all that. You need to be able to identify that. The third thing that I wanted to talk about was identifying prominent symptoms. So when you're looking for, okay, this person looks depressed, or this person looks anxious, or this person's psychotic, for me, the 3 big things that I start to identify are those: anxious, depressed, and psychotic. And I know that there's the third kind of mania, the opposite of depression, but that doesn't always look just like mania. It looks in a lot of different ways sometimes. Sometimes it looks somewhat psychotic. Sometimes it looks, very happy. So it's hard to tell, but I start looking for these prominent symptoms. And then, the good part with psychiatry is that we're treating symptoms. We're not always treating diagnoses. So we have antidepressant medications that are broadly called antidepressants, though the SSRIs are indicated for anxiety. They're indicated for obsessive compulsive disorder a lot of times. They're indicated for depression, obviously. They're indicated for a number of different things. So as far as what's the accurate diagnosis, sometimes it's hard to tell on the first time, but there's always the F39 is the ICD-10 for unspecified mood disorder, and F29 is the ICD-10 for unspecified psychosis. So unspecified is kind of, it's an okay thing to use. This person looks psychotic, this person looks depressed, this person looks anxious, and we're treating those symptoms. So identifying a major symptom set when you're working in primary care or adult general care, if you're in cardiology or ortho, it doesn't matter, and you're comfortable treating these psychiatric illnesses. I look at it the same way as when I have someone on the inpatient psych unit and they have mild hypertension, I'll prescribe lisinopril, something like that. It's something that's easily treated. It's something that's not grossly out of the ordinary. It's, if they have depression and they show up in the primary care clinic, at least they're there. 96% of the counties in the whole country don't have any psychiatric coverage at all. So it might be the primary care office is their only line for treatment in depression, anxiety, those sorts of things. So we've talked about the making sure that you've got all the substance use history taken care of, what substances they're using, how frequently they've used them, gathering the accurate history overall, making sure that you're talking to multiple different sources and making sure that you're getting as accurate and thorough a picture as you can in terms of their history. And then the third thing is just identifying a major symptom set and then trying to get yourself comfortable to treat that symptom. If it's psychosis, no one's gonna shun you for referring that on to psychiatry, which makes total sense. And if you're kind of worried that this person might be manic versus just anxious, then of course you're going to refer that on. But there's a lot of times you're able to identify kind of the bread and butter depression off the top of like the first couple minutes of an interview and start an antidepressant or an SSRI and monitor them yourself, which is definitely being encouraged. So the last thing I wanted to speak about was suicide, and it's always something that nobody sees. It's not always something that nobody sees coming, but it's always something that it's difficult to talk about because there's actually really no crystal ball, no guidelines. There's predictors, there's things that you would want to watch out for with warning signs, but by this point you've heard all of those. So the big thing is that if you get anybody who has any mention, any kind of small spot of suicidality, I guess you would say, they mention anything about feeling like they might want to hurt themselves or that they've been thinking it recently, is to refer that on. I've always been a huge proponent of that. I've been called to the emergency room for PsychCL, which is consult liaison, to assess someone who's reporting suicidality. And it ranges everywhere from like, I'm not suicidal now, I just said that sometimes I think about it, I don't think about that now, I don't want to do that, to, yeah, I'm actively suicidal now and I have a plan to jump off a bridge or shoot myself or hang myself or whatever. I think just asking the question is most people's hardest thing. And once you've asked it 1,000 times or something, 60 times a day to all of your patients, it gets to be a little easier. So the biggest thing is making sure that you're asking every patient every time, just the same as you would ask about, any sort of other history or performing an accurate and full physical assessment. It's the same thing, but with psychiatry, we have to ask all the questions. So making sure you're doing it is the first step. If anybody has any questions, or if they just, or if you just want to send me, questions to ask about kind of real real world experience, my email address is michael, that's michael.eaton at tmcmed.org, and that's Truman Medical Center where I work at here in Kansas City. Thanks for watching the whole 15 minutes, and let me know if you have any questions. Thanks.